Good afternoon, everyone. I'm Stacy Sennett, Program Director at the National Kidney Foundation, serving New England. I would like to thank everyone for joining. As we wait for additional attendees to join the webinar, I would like to take some time to go over some features you can utilize during our presentation. All attendees have been muted, and for any questions, please use the Q&A window. The Q&A window will allow you to ask questions to the presenters. To locate the Q&A window, hover your mouse over the screen, click on the Q&A tab. Once open, you can type in your question into the Q&A box. Click send. The speakers will then answer your question live after the presentation. We can't promise all questions will be answered due to time commitments, but we'll do our best. We would like to thank all of our attendees today and our speakers for joining us. Again, thank you for all joining this afternoon. I would like to introduce Medical Director of Kidney and Pancreas Transplant Program at Brigham and Women's Hospital, Dr. Chandraker.
So thanks, Stacy, and welcome to everybody. Thank you for joining us today. The latest webinar in our series of Kidney Crossroads, which is a joint collaboration between the Brigham and Women's Hospital and the National Kidney Foundation of New England. We try to tackle topical subject matter for the transplant community in these webinars and give the audience an opportunity to interact with our faculty. One of the important areas that we see both pre and post transplantation is obviously weight gain and weight loss. And weight gain actually and being overweight is one of the most common reasons for patients not being eligible for transplantation. And there have been a number of studies and changes in the way that we think, and also treatment options in patients who are overweight in recent years. And the way that we treat patients and think about them in transplant setting has obviously changed. So today what we will do is we're going to have two speakers. One is Tom Tsai, and the other is Joel Adler. Dr. Tsai is going to talk about the medical, endoscopic, and surgical therapies for weight loss. And Dr. Adler is going to talk about the impact on kidney transplant candidates and recipients. Dr. Tsai is an assistant professor of surgery at the Harvard Medical and is a faculty member at the Brigham and Women's Hospital. He is a bariatric surgeon, and he's also the director of clinical care design in the Department of Surgery, which basically means trying to figure out new and novel ways of integrating care for patients at the hospital. Dr. Adler is one of our transplant surgeons, and his research area is epidemiology of transplantation, and he looks at lots of studies that look at the outcomes, both pre-transplant and post-transplant, in terms of how they affect the way that we think about transplantation. So as Stacy said, we're going to have two talks, and then we're going to have a question and answer session where you're free to type in questions and we will put them to our speakers. So with that, I'd like to introduce Dr. Tsai for our first talk.
Great, thank you, Dr. Chandraker, and let me get my slides pulled up here. Actually, 1 second here. Share screen. Great. Thank you for the invitation to participate as part of this Kidney Crossroads webinar. As Dr. Chandraker mentioned, I'm a bariatric surgeon and director of clinical care redesign at Brigham and Women's Hospital. And part of our paradigm shift in terms of how we want to redesign our clinical care is to really focus on the experience of the patients, and have the clinicians really work in a collaborative way, hand in hand, and all work together and build a team around each individual patient, because we understand that each individual isn't just an individual with diabetes, an individual with kidney disease, like individual with obesity, but that that these all are interrelated, and it's our job to work together as a team and bring that collaborative team-based approach to help all our patients live longer and better quality of life. For this first half, I'll talk a bit about the metabolic approach to treating obesity, which is a comprehensive approach involving surgical care and GI care, as well as medical endocrinology, obesity endocrinology care, and the collaboration of dietitians and psychologists. But first, I want to describe a paradigm shift that we've had around how we think about metabolic syndrome and think about weight. And it's that, kidney disease and metabolic health are really two sides of the same coin. And that a lot of the risk factors and comorbidities that we talk about, these medical conditions are all related. And if you think about starting with obesity or a higher weight, which we measure by the body mass index, that's associated with diabetes, which is also associated with a host of cardiovascular, so diseases of the heart and blood vessels, such as high blood pressure, high cholesterol, which can lead to heart attack and stroke. And all of these can culminate in injury to our organ systems, and of which one of the most important ones is the kidney, resulting in end-stage kidney disease. So instead of thinking about medical treatment for each of these individual conditions, we want to take a more comprehensive approach and really treat all the conditions together that are really impairing the life and livelihoods of our patients that we treat at Brigham and Women's Hospital. So we're very proud of our approach, and this is a collaborative effort across the Center for Weight Management and Wellness, which is a multidisciplinary team focused on weight and metabolic health, as well as our kidney specialists, such as Dr. Chandraker, as well as our transplant surgeons, so that from day one, we bring that comprehensive approach to patient care. But specifically focusing on our approach to obesity, we pride ourselves in taking a comprehensive approach, and that we work collaboratively as a team to really tailor the best treatments to our individuals based off an individual recommendation. So this multi-pronged approach includes surgery, which is a minimally invasive bariatric surgery, and we've been really thinking about it as a metabolic surgery, which we'll talk about in a little bit as we look at some of the data in terms of how powerful the operations are in terms of reducing the cardiovascular risk factors, diabetes, and reducing your weight. A second complementary approach is endoscopy, which is performed by our bariatric gastroenterologists. Another key and core part of the team are our medical specialists, and this includes obesity endocrinologists, who are medical doctors who specialize in treating both diabetes as well as weight with medications. We'll talk about in a little bit the very exciting developments that have occurred with some of the medical management for weight loss and diabetes. But this also includes our nephrologists, who are very important colleagues and part of this team, because they have a very longitudinal relationship with you, their patients. So we want to work hand in hand with our medical colleagues as well. And the backbone of this as well is a healthy lifestyle, which includes a team of dietitians and psychologists. So this is our efforts to really redesign care around the patients, as opposed to focusing on each medical silo, and bring the best of that multidisciplinary approach to the bedside and to the clinic. And what that means is that there is a tailored approach for each individual patient, and there are benefits and advantages and disadvantages of each approach. And our goal is to really get to know our patients, work closely with our nephrologists and transplant teams to be able to tailor individual approach and strategy, which may involve different combinations of the different treatment options. I'll start off with surgery, but go through the rest of the medical as well as endoscopic options. Surgery is indicated, meaning it's covered by insurance and for what we call class 2 to class 3 obesity. So it's a body mass index of greater than 35. Now, there is data that patients at a lower weight can benefit from weight loss interventions as well, and that includes the endoscopic approach. The advantage of the surgical approach, it's that there's over 5 decades of experience with weight loss surgery and over 3 decades with the laparoscopic or minimally invasive approach, which is through small micro incisions. There are long-standing durable outcomes, and on average, patients can expect to lose about 20 to 30% of their total weight, which is about 50 to 75% of their excess body weight. And what's really powerful is that not only does surgery and some of these treatments actually improve your weight and the risk factors, but ultimately it increases your life expectancy, and we'll look at some of that exciting data later. The second complementary approach is endoscopy. So using cameras to look at and treat within the GI tract itself. It is innovative, and there's a lot of trials and development of this, especially around the world. But in the US, it is only offered at select centers, of which Brigham Women's Hospital is one of the national world leaders in implementing endoscopic approaches. And this includes using the endoscope to, in a minimally invasive way, recreate some of the operations that we're doing through the laparoscopic surgical approach. And you can expect to lose about 10 to 15% of your total weight. So less powerful, but still a very important part of the treatment paradigm, especially for those patients who don't meet insurance requirements for weight loss surgery, but can benefit from the endoscopic intervention. So if their BMI is between 30 and 35. The next 2 parts really are the backbone of any weight loss program, and that is the medical weight loss approach, which patients of any BMI can benefit from, either in lieu of surgery or endoscopy, and oftentimes in a complementary approach, so using medications along with weight loss surgery or weight loss endoscopic management. There are several medications that are available, from oral pills all the way to new injectable medications that are highly, highly effective. A series of new trial data has shown some of these newer medications, which actually alter your body's metabolic pathways by changing your body's response to insulin and ability to produce insulin. Has been very helpful, not just for treating diabetes, but also in treating obesity. So it's a 1-2 punch, so to speak. And these medications, the newer injectable medications, have been able to help patients lose weight of 10 to 15% of the total weight loss. Some of the oral medications are capable of helping people lose weight in about 5 to 10% range. One downside of the medical approaches, it does require you to continue to take medications, whether it's the pills or the injectable treatments. And the last part is the healthy lifestyle, which is important for any body mass index, and really is what is the backbone of a lot of these interventions. And the way I describe to my patients is that obesity is like trying to run a marathon, and you're running uphill. You're working very hard. It's hard to see progress to others and for you to see progress in terms of forward movement, but you're working really hard. And what surgery and a lot of these other approaches do is they really flatten the curve. They're not shortcuts. What really are is they make the possibility of finishing the race possible, but everybody still has to, run the race. And running the race is that healthy lifestyle, making those healthy decisions about your diet, about exercise, and they are the core of all of these approaches. But if you only have the diet and exercise alone, it can be hard to maintain that without the benefit of the medical approach, the endoscopic approach, or the surgical approach. Here's some data on specific to bariatric surgery. As I mentioned, the goal is to not just live a better quality of life, but also live a longer life. The data looking at what we call major adverse cardiac events. So these are outcomes such as death, heart attack, and stroke. Patients who undergo weight loss surgery, metabolic surgery, have a 38% lower rate of the major adverse cardiac events. For diabetes, in the randomized controlled trials, it's called the Stampede trial, where they followed patients who were randomized into medical treatment only of their diabetes, laparoscopic sleeve gastrectomy, or laparoscopic Roux-en-Y gastric bypass. And we'll talk a little bit about the surgical options in a moment. And the 5-year result of those data, the surgical arm, so the 2 surgical bariatric operations, were able to decrease the hemoglobin A1C by 2.1%. So if the patients are averaging around 9, they'll get it down to 7 in a very durable way after 5 years. It decreases the rate of individuals needing insulin by 35%. And 45% of individuals were able to have remission of the diabetes, meaning completely come off of medications while insulin or oral medications with a normal hemoglobin A1C 5 years after the weight loss surgery. So a very powerful tool. But most importantly, by reducing these risk factors, by reducing the weight, reducing the heart attack and stroke occurrences, by decreasing diabetes, what it really means is, and what people care about is living a better quality, but a longer life. So on average, this is new data just came out last week in the Lancet, which showed that on average, individuals after weight loss surgery can live 6 years longer. So 6 additional years than similar patients with the same set of medical conditions. And if you're diabetic, it's an even more powerful tool where on average, people can live 9 years longer. I mentioned a few of these surgical approaches, so I'll briefly cover them. It's not meant to go into more detail. Happy to talk a little bit more in the Q&A period about both the surgical approaches, the endoscopic approaches, as well as the medical approaches. But the most common operation is what's called the sleeve gastrectomy. So about 80% of patients are choosing this operation nationally. And what we do is remove the parts of the stomach that basically slow down the time it takes for food to move through, and by turning the stomach into the size and shape of about a banana. The part of the stomach that's removed also creates a hormone called ghrelin, which stimulates the appetite. So really the surgery is not just making your stomach smaller, it's really rewiring your body's internal metabolism, which is what's important for achieving some of the outcomes we saw earlier. On average, it's an hour operation, and patients stay 1 day in the hospital. The gastric bypass is an operation that's had 50 to 60 years of experience nationally. So a very well described and well-known operation. It's also done laparoscopically, but it's a more involved surgery where we turn your stomach into the size and shape of about an egg, 30 to 50 cc's. We have to reroute your intestinal tract to bypass the upper portion of the intestines. It's a more powerful operation. You can lose up to 30% of your total weight. It's a longer operation, but has a slightly higher post-operative issues we have to keep a close eye on, such as nutrition deficiencies and potential intestinal blockages, which are rare, but events we want to be careful about. I'll mention the lap band only because it was a common operation about 10 to 15 years ago. The lap band wasn't very effective because all it did was make it difficult to eat a lot, but didn't actually have any of those powerful metabolic hormone effects that really are important for making people ultimately not just thinner and with lower weight, but actually healthier in the long run. I'll end on this last slide. And a key question that patients often have is, are these results durable, or is this just a shortcut? And then this is a really long-term study, 24 years of follow-up of patients from Sweden. And they looked at patients that underwent weight loss surgery versus control. So similar patients of similar age, similar sex, similar body mass index, similar panel of medical conditions. They showed that the weight loss was really sustained, which is the orange line. So you see that lower weight loss compared to that blue line all the way out to 20 plus years, so that these are very long-term outcomes that can be lasting and life-changing. And most importantly, we see on the right side there, which is the life expectancy curves. So in this older study, they showed about 3-year longer life expectancy. So see the orange line being higher than the blue line. So so orange line is surgery. Those patients lived on average 3 years longer than the patients who are obese but didn't have the operation. So this results are very, very durable in the long term. So with that, I'm going to stop there with the overview of the bariatric operations overall. I'll turn it over to Dr. Chandraker and Dr. Adler, where we'll talk a little bit more detail about what this means for the patient with end-stage kidney disease and for renal transplant.
So, Tom, thank you very much. That was very informative. And now we're going to move over to Dr. Adler. And then after Dr. Adler's talk, as I said before, we'll take questions. And you'll have an opportunity to ask Dr. Sai and Dr. Adler about the presentations. Over to you, Joel.
Thank you, Dr. Chandraker. And thank you, Dr. Sai, for such a really important and impressive overview. And I think really what I hope part of the message that you're all able to take away from that is that there's a lot of nuance to the decision that's being made and kind of the way that you work through it and how this works in terms of weight loss and the approaches that we have. But I think one thing that's become increasingly clear is that these were generally procedures that were limited to people with fewer other health problems. And so what we're learning now, both from long-term data, as well as thinking specifically today about it in the advanced kidney disease, as well as renal failure and transplant population, is that those are the people who often need these treatments the most, in the sense and can benefit the most from them. And so that is something that I plan to talk a little bit about right now. Talking again a little bit about what it means in terms of graft loss after transplant, what those outcomes are of bariatric surgery, both before and after, other considerations, and then just some of the things to think about. Should this be something that makes sense to you or as part of what your overall care plan may be, or in any way for your overall health, what that actually means in terms of transplant. So one of the interesting things, and this is actually older data, and one of the great things about this again is that we have a lot of data and a lot of durable long-term follow-up for many of these procedures now in the context of transplantation and end-stage kidney disease, is that what we know is that there's probably something a little bit of a Goldilocks effect with relationship to weight, as well as how well kidney transplants actually do overall. And so this graph is an old figure from 2002. And what this will show to you is that as the body mass index kind of goes more towards what is considered to be a normal-ish weight, again, by BMI, which of course is not the whole story, but there is something associated with it on a population level, of roughly between 18 and 25, the risk of graft loss, which if you think about 1 being normal, is around, or 1 being, sorry, the average risk, increases with a higher BMI. And also, interestingly, with a lower BMI as well. And so there's definitely a bit of there's a health thing, and this has been known for a long time, that this matters in terms of after transplant, how long your kidney graft will actually last for. So higher being worse in this figure. And this gets a bit back to what Dr. Sai was mentioning before about who and when we should consider it. Now, as he mentioned earlier, either class 2 or class 3 obesity, meaning a BMI of over 35, is the indication that most insurers will account for a bariatric procedure or any sort of advanced therapy. And in this situation, along with any sort of obesity-related comorbidities, is what qualifies once you're over 35. And anybody who would be, almost anybody who would be involved with the National Kidney Foundation for any reason, qualifies under this category here. And there can't be any attached endocrine causes of obesity that might be doing that. Most transplant programs, and this is a broad statement and roughly guidelines for us, but certainly by no means a strict and strong exclusion, look for our donors on the flip side to be somewhere less than 35 for a BMI, and our recipients to be less than 40. Now, we say that also, again, realizing that there needs to be some consideration because there's some timing issues related to that, especially when we're talking about transplant. There's also some thoughts that, and there's also the reality too, that a lot of people who are on dialysis have significant enough fluid shifts that these numbers actually can go around quite a bit depending on where they are in the course of their disease. And so these are guidelines that we think about, and these are the things that we go for. And one thing that I'd also point out, and I hope that the slide before also made somewhat clear, is that this is not necessarily, in fact, isn't at all, to make the surgery or the operation part of it any significantly different. The real reason that we do it is because we're interested in long-term health of our candidates, recipients, and anybody that we see, and also, of course, for the length and life of the kidney. Certainly, the number of kind of peri-procedural complications, such as wound infection and other problems, are lower with a lower BMI. But the reason, again, despite potential joking or whatever it is that may come up sometimes, it has nothing at all to do with the operation itself, or very little. It has much more to do with what your overall long-term results might be. So this is, again, something that we have been able to study now that has been occurring more and more often throughout the United States. And so this is a figure of 4 different panels, and I'll walk you through what these all are. But this is looking at what happens in people who have a kidney, who have bariatric surgery of any variety, which Dr. Sai mentioned before, while on dialysis. So this is that category of patients. But then before they have a kidney transplant and what actually happens. And so this is about 1,600 patients who make up these cohorts. And those are the ones that are in the blue lines that you can see. And what you'll see first in the upper left-hand corner is just that mortality risk that Dr. Sai mentioned before. People who have a bariatric procedure and or are able to achieve a lower overall BMI do in fact live longer, and there is benefit from that. And even more so, the majority of that was actually, again, to what he mentioned before, from a reduction in those cardiovascular events. You see here, it's the death from cardiovascular causes. And the way you read these is that mortality is going up over time in the orange, which is the group who didn't have an operation, and then it's less so in the blue for all those things. There's another related thing, which I mentioned before, about infectious causes in general, just looking for other reasons that people die. But the most interesting part of this data, which I think is also where we kind of pull into all of this, is that patients who had that done, who had some sort of a procedure to be able to enable weight loss, were actually also transplanted sooner. And that has to do with being able to be active on the list, being able to deal with all the other conditions and issues that get you all the way to transplant. But these are the things that we really like to think about. So if you look at them overall, right, at about a third of a less risk of death in that risk of death overall, lower cardiovascular risks, and then also an increased opportunity and chance of being transplanted. That has nothing to do with the allocation. That is just more to do with people's overall health and how their course goes. So that's the before transplant picture. But then what about after? We don't have nearly as good or even as much data to say people who have a bariatric procedure after transplant, how they do, to be able to make any long-term conclusions. I suspect they wouldn't look all that different from the slide before, although we can't actually say that for sure. But what we can know is that, is the procedure itself safe after transplant and even also beforehand? And this is a slide looking at what those options are. So in this column here is a number of different complications that can happen after surgery. And this is after, in particular, bariatric ones. And the couple things that will come out of it is that there is definitely an increased risk of all of these things happening, of the risk happening if you've had an organ transplant before, just after with bariatric procedures afterwards. Sorry, just skipped a slide that way, sorry. There is an increased overall risk, but it's largely modified by how well the kidney actually works afterwards. So the actual point of the slide is, while there are a couple of them that do sometimes occur more frequently in patients with transplant, even after surgery, when those benefits still definitely exist, the benefit to patients is still probably worth the trade-off at that point. And so some other considerations for patients with end-stage kidney disease overall is, I think, getting back a little bit to what but to what Dr. Sai was mentioning before, is the procedures themselves rather carry with them a benefit just beyond what that number might be, right? It's not all just about the BMI. There are a number of metabolic effects that actually are quite helpful that go along with it, the hormonal balance changes, and there's just genuine health improvements that again are not just attached to that number, but everything else that goes along with it. One other consideration for patients with end-stage kidney disease is that there is a bariatric vitamin regimen that's required. There's the possibility of micronutrient deficiency. So some of the procedures, especially a gastric bypass, can lead to those in a population without kidney disease. And this is something that we also need to look out for long term. You want to think about what the timing of transplant or bariatric surgery might be. Again, there's something that comes up. So if somebody were to come in at a higher BMI, but have the possibility of a living donor, I think Dr. Schenriker could comment on this later too, that becomes a bit of a complicated calculus. It's one thing when we know that we may be waiting on the wait list for between 4 and 7 years, waiting for a kidney, and then we can start to approach these therapies and optimize before transplant. But how do you actually approach that in the setting of the possibility of a living donor, or whatever you do with that? Like, how do you deal with these things? So again, to optimize both the outcome for the patient as well as the kidney itself. And certainly you may have also learned as going through that there is something called the obesity paradox in reference to patients on dialysis, that people at a higher BMI tend to do better on dialysis. I think overall that may be more of a population artifact, but that is certainly something that you can see depending on the studies that you look at and the like. But that again is more of a population level finding versus maybe a more personal one that we are talking about today. As I mentioned before on the previous slide, the timing of when to consider something like this, if it were required or necessary or thought to be helpful, really depends a lot in terms of the kidney side, in terms of the availability of living donors, as well as what the expected time to transplant might be. If there's a number of other medical comorbidities to approach or other issues that need to be sorted out, depending on how things are. And I think we can talk a little bit in the Q&A about what the time frame of this tends to be, like when, how fast weight loss is afterwards, as well as then when that might put you in a good spot for transplant. We can cover that. But then if you're somebody who's on dialysis and not really interested in kidney transplant or looking for it long term, you need to make thoughtful decisions about, is it consistent with your long-term goals? And then again, what the quality of life and metabolic benefits are. Like everything, it's a risk-benefit situation. It's hard to predict for any one person exactly how it will work out. But what we do want to point out, again, of course, that is a complex decision. That's a safe thing to consider. And that it does require a very nuanced and thoughtful discussion. So I would say conclusions from both Dr. Sai's and my talk is that obesity is a significant risk factor for ESKD and for kidney transplant, and a comprehensive approach can certainly improve health outcomes. Associated with a higher risk of losing a kidney transplant afterwards, I mean, the risk of it will just not last as long. There's certainly a number of methods, again, surgical and not, that have a huge role in all of this management, and some of them are very exciting in terms of endoscopic and medical therapies. Bariatric surgery itself is safe and effective and overall improves transplant candidacy. Probably better to do the surgery prior to transplant if that works out. But again, that's a decision that can be a bit tricky depending on dialysis, etc. But that again, an individualized approach really is crucial. And the more and more that we get into this, the more and more that we apply higher risk procedures to a higher risk population, we have the experience and the data to support what we're actually recommending and doing. So with that, we can stop here for the Q&A. We'd be happy, of course, to take any questions that might be around.
Great. So thank you both, Dr. Adler and Dr. Sai. So I think that's very informative. While we're waiting for questions to come in, I thought I would start with the first question. In fact, there's already a question that was asked, but I want to broaden it a little bit. So we often get asked about supplements, tablets, diet tablets, and that haven't been regulated, particularly those associated with increasing your fat burning and ketone promoting tablets. Do you have, so maybe I'll ask you first, Tom, do you have any advice for patients who are thinking about doing this?
Yeah, I think this sort of probably a truism is go speak to your doctor first about this, and that's why we want this to be a team-based approach. And we want this to be a collaborative effort. So if you have a question about a specific medication, speak to your nephrologist. Speak to our weight management team, and we actually have a specific collaboration between our weight loss dietitians and the nephrology and dialysis dietitians work with that program to help streamline some of the medications and supplements. But I think it's important to understand that for weight loss, as well as most medical conditions, there are very few shortcuts in life, and you need to really do it the right way for your health in the long term. And I'd be wary of a lot of the advertisements. And there are ways, there are ketogenic diets that can help you lose weight through a diet modification and exercise, but that needs to be done in the context of a comprehensive program that is also making sure that it's good for your health overall. So generally speaking, the over-the-counter supplements don't work very well. There's some danger of them actually having some harm, from a kidney, liver standpoint. That's on the extremes. Most of them are just a waste of money. That's probably the biggest harm. But I think the overall lesson is, speak to your medical team. And again, I think the whole point of these collaborations is that it's nothing is really out of anybody's lane anymore, because from a medical standpoint, because we all draw on each other's expertise to kind of provide that sort of feedback to our patients.
Joel, do you have anything to add?
I would agree with what Tom had to say about the issues. Certainly, it's always a discussion to have, and I do think, again, that being thoughtful and being able to work together across and between, again, these used to be things that we would never dream of doing in people with long-standing and advanced kidney disease, or even on dialysis, or very infrequently. And we've been successful at being able to build that partnership and be able to figure out ways to do it safely and to have good outcomes.
And what I would add to that is that I think the problem, broadly speaking, with supplements is that we don't really know what they are, right? So often they haven't been tested in trials or clinical studies. So it's very difficult for us to advise on whether they do good, that they have the potential to do harm. Remember, clinical trials are set up not just to detect the benefit, but also to make sure that no harm is being done by any particular medication or supplement or therapy. I think the second thing is that supplements are not regulated in the same way that medications are. So you don't know if there's batch-to-batch purity, if you're taking the same thing. There are changes within the ingredients. And so it's very difficult to know, even if something has been shown to work, whether that is the same treatment that you're taking from month to month if you're getting it even from the same supplier. It's just the testing is not as rigorous. There's no requirement. They often get through and are for sale over the counter because they are classified as supplements or naturally occurring substances. And if you go to different parts of the world, for example, in Europe and the United Kingdom, the vast majority of these supplements are not available over the counter because they have stricter rules about what can be supplied. So you have to be very careful, and often, we don't know. As physicians, we don't really know. We can't tell you because we don't have the data. And so there's always a big problem there. But I totally agree with what Tom said, and that is that you really should be asking your doctor, should be discussing with them. There may be certain conditions that indicate an absolute contraindication to certain medications or supplements. And so you have to be very, very careful about that. I mean, we don't ask patients to prescribe their own medications. So we don't really ask you to decide on what supplements you take, but we can't really advise you as to the benefit and harm of those. So another question I have, Tom, is, is there an age limit in terms of bariatric surgery or approaches as to when it's viewed safe or desirable to be doing this?
Yeah, that's a great question. And I think for most centers, about 80 years of age or higher is sort of the upper limit of when we would offer surgery. And that's for a couple of reasons. And sort of 70 to 80 ends up becoming a real sort of case-by-case determination. One is, if you think about one of the ultimate goals of surgery, which is to increase life expectancy by decreasing these risk factors. At a certain point, as you get older, there's sort of less time to see the benefit of the operation. Right? I showed you the data from Sweden, where if you follow them out 24 years, those patients have lived 3 years longer. But if you're 80 already, the benefit may be less obvious just from a life expectancy standpoint. So most centers do not recommend bariatric operations above 80. 70 to 80 becomes a more case-by-case determination of the risks and benefits and the goal of surgery. Are you trying to do surgery for overall health benefit in the long run? Are you trying to reduce the risk for a kidney transplant, which is actually the case of a shared patient that Dr. Adler and I have coming up in the next couple of weeks? For that very specific reason, it's very life-saving. Offering the operation in somebody in their 70s really does make sense in a very motivated patient. And the last thing I'll point is that, like I said, a lot of the backbone of this is a lifestyle in terms of the diet and exercise. And sometimes it's hard for somebody who's in their 70s to change, what they've been doing, over the course of their life. So it's all about that individualized approach about, the risks of surgery versus the benefits, which is for most people, the benefits outweigh the risk. But as you get older, any sort of procedure has its own risks. So we're more thoughtful about really trying to, recommend, the right approach, which may mean medications, or endoscopic approach, which may be sort of less of a stress on the body. But that's the general approach that we take.
Yeah. Okay. Thanks, Tom. The next question is, if a patient's post-transplant, how can they get help so that they avoid seeing you, Tom? They don't want surgery, either endoscopically or bariatric surgery. So what resources are available at the Brigham? Yeah. And to help with diet and weight loss?
That's a great question. And when I was a resident, one of my senior surgical mentors used to say to his patients as he would leave the room in the clinic, Mr. So-and-so or Mrs. So-and-so, please try to stay away from people like us. So you want to have a nice surgeon, but you don't want to be meeting them in the recovery room or the operating room or the emergency room. So for a lot of patients, surgery isn't the only. It's a very powerful tool, but it's not the only tool. So that's why at the Brigham we've taken this comprehensive approach through the Center for Weight Management and Wellness. We deliberately didn't call it, the Center for, Weight Surgery. It's really about the goals of the patients. And we have a common referral system, a single phone number that will let you reach a new patient coordinator, who then will ask you some questions about your goals and, your weight, and then efficiently direct you to the medical specialist, the obesity endocrinologist, or the obesity gastroenterologist, the GI doctors who do the endoscopic procedures or the surgeries. And we even have a path, just to make it very transparent, that you can see the surgeon, but as a consultation only, not because you want to go down a surgical path. So we try to make it very streamlined for patients through the Center for Weight Management and Wellness at the Brigham. So you're not, seeing one provider, but then referred to another provider and sort of being bounced around. We want to make sure that from the very beginning, that we get you to the right person that you want to see. So in your case, call the Brigham, the Center for Weight Management and Wellness. That patient coordinator will be able to direct you to the first provider based off of your preference. realistically, we work collaboratively. We have a weekly multidisciplinary meeting where we end up sort of weighing in and brainstorming on the best approach. So it really is a team-based approach, sort of behind the scenes anyway. Start by calling that Center for Weight Management and Wellness number. You can Google the website. There's videos, patient testimonials, and then also the very easy single phone number to reach.
Right. Thanks. So, so you both talked about BMI, and I think patients, I think most people sort of have an understanding of what BMI is, and there are calculators online where if you know your weight and your height, you can calculate the BMI for yourself. But Joel, maybe I'll throw this out to you. I think you alluded a little bit, but so BMI is an approximate measure of obesity, but it doesn't apply equally to everybody. And the question really is BMI the best measure? Are there other things that we should be thinking about in different populations? Are there sorts of measurements that might be more important? And what is it that you, as a transplant surgeon, what is it that you worry about in patients who are above their ideal weight specifically?
Sure, that's a great question, and to your point, it's a complex one. Certainly there are calculators and ways you can figure this out online. Certainly apps for your phone, etc. And anytime the moment you try to Google finding a BMI calculator, then you'll also come up with a number of results that we'll talk about why the BMI is not an ideal indicator for kind of any one person. And I think that's actually true. One of the things I hope also came out of the presentation today is that the BMI as a number is great for kind of population level things, right? For thinking about things kind of on average or for a group of people who are like that, but it's very poor at kind of any one individual person's predictive abilities. And so one of the things that we certainly consider, and I think from the surgical standpoint, is how that weight is distributed. Kidney transplants go into people's pelvises that we connect to the blood vessels going down their legs, one side or the other. And one of the things that we think about in terms of like the technical concerns and considerations are kind of what that space looks like and how people's weight is distributed. Is it more central? Is it more in the limbs, etc.? And again, that also changes a lot in terms of people on dialysis and the way that they otherwise view their weight kind of even in between sessions and the like too. So I don't think there's any necessarily great individual predictors or improvements in terms of BMI and the way that things are measured. I do think that taking again a bigger thoughtful approach to it and the like is an important one. Tom, I don't know if you have anything else that you in particular look at in clinic. I mean, certainly there's a comprehensive metabolic assessment in general, and that the BMI also tracks usually in certain ways with that, but I don't know what other measures you might use kind of in your evaluation process.
Yeah, we're relying on the body mass index currently, but there's very exciting new research that combines machine learning and sort of computer vision, so letting the computer define algorithms of different patterns of fat distribution. So we've looked at waist circumference, that's been used by the cardiologists and the internists for risk stratification, but there's a lot of research using machine learning techniques to look at different patterns of fat distribution, and there is some data that the fat that's sort of carried inside the abdomen, so around your intestines, around your organs, that sort of pattern of weight leads to more of these cardiovascular comorbidities. So the science isn't so nuanced that's been part of our decision making yet, but I think that's the exciting part of this whole field, is that there's so much new research, so much new data across different disciplines that's all sort of focused on helping us tailor with more precision the right approach for our patients. But for right now, we're really still focusing on body mass index in conjunction with the other patient-specific risk factors and considerations for the operations.
Right, and that actually leads me to the next question, which is, what exciting research, new methods do you think are you excited about that are going to be coming coming into clinical practice, or that may help us in understanding how to improve weight loss in patients? What do you see coming down the pike that may be of interest to patients in the community?
Yeah, I'll sort of jump first, and and love to hear Dr. Adler's thoughts as well. From the obesity standpoint, as a bariatric surgeon, we always joke that eventually we will be put out of jobs when they discover a pill or a shot that that treats obesity effectively. And in some ways, that's the goal, right? Is for us to understand the mechanism of the disease so well that we can treat patients effectively with a non-invasive approach. And there's very exciting new data, and I mentioned this at the beginning of the conversation today about some of these newer medications that were initially marketed and designed for treating diabetes, but they have some outcomes where they're comparable to the endoscopy approaches now. Not quite as powerful as the surgical interventions, but I think it's a matter of time where we will get really understand all the different mechanisms. And I think the challenge is that on the medical side, there may be a cocktail of sort of medical regimens that harness all the different pathways of obesity, some of which are common with diabetes and other conditions, that can take a multi-pronged approach to solving this. So I think a lot of as a surgeon, honestly, like I'm most excited about the developments on the medication front. There's a lot of really innovative endoscopic approaches to treat obesity as well. And there's a lot of trials that are being done internationally. They include replicating the surgical operations endoscopically, so the endoscopic sleeve gastrectomy, which is similar to a laparoscopic sleeve gastrectomy. There's even resurfacing of the intestine. There's barrier linings to the intestine. So there's a lot of innovation on that front. Those data are still early, and in some ways, I'm less excited about the endoscopic approaches because of the biotechnology itself. But more importantly, it's those endoscopic interventions have totally changed and revolutionized our understanding of how weight loss works. So the resurfacing endoscopic procedures, the intestinal lining procedures, they've helped us move beyond understanding that we need to make the stomach smaller, make it more difficult to eat. That's not how all this works. It's really pushed the science to understanding the physiology of obesity and the physiology of our GI system. So I think it's a combination of the physiology, which is really being pushed by some of the endoscopic approaches, which then is leading to understanding of the medical side. But again, I think all these three things work together. But again, as a surgeon, ultimately, my hope is that someday I am put out of a job, and we have a better, more precise, and less invasive approach for our patients, which is what all of us would want if we were patients.
Great. And Joel, so there's a question here asking, how long do I have to wait to get transplant after weight loss surgery?
That's a great question. I think Dr. Sai and I, at least in our shorter term approaches, have agreed that people settle out with their weight loss afterwards at about a year after the bariatric procedure is done. And that's probably roughly about the right time frame to think to actually undergo transplantation afterwards. That's just so that your body is adjusted, the fluid status has balanced itself out, and that also then that we're set, and that from a metabolic perspective, that the immunosuppression will be consistently and somewhat, maybe not predictably, but at least metabolized in a consistent way, so we can monitor that post-operatively. Tom, you agree with that assessment on timing?
Right, and that coincides with when the low points or the maximum weight loss occurs. But also, again, the surgery is reducing the risk, so you need to sort of have the time for that risk to be reduced. And there's an optimal window. If you do it, you could do it sooner, but you haven't sort of gotten the return on the investment, so to speak, of the health benefit from the operation. You wait too long, and then you other things could happen. You lose that window of opportunity. So a year, give or take a few months on either end is generally the right window to kind of think about staging the transplant after the weight loss procedure. But again, like with everything, it's depends on the individual circumstances of the patient.
And then I think, I'll just ask you one final question. It's a question I guess we don't really like to talk about so much, but obviously when people undergo surgery, nobody really wants to do surgery unless they really need it, as you really mentioned before, Tom. But what are the potential side effects and how do you avoid or how do you decrease your chances of having these side effects?
Yeah. That's a great question. So it's a big operation, and while the C gastrectomy takes about 45 minutes, it does put a deal of stress on your body. I think of the complications in sort of three buckets. One are sort of technical outcomes from the operation. The second one is sort of the physical stress of the surgery, which is a combination of surgery plus the anesthesia. And the third is the underlying risk factors from what the patient kind of brings to the table, so to speak, because of the medical profile. So the things we think about from a technical side is there's a risk for leak, from the staple line that's less than 0.1%, so less than 1 in 1,000. So 999 out of 1,000 times it doesn't happen, but it is something we are very vigilant about by checking labs and following our patients closely. There's a risk for there's a lot of technical things we do to optimize. We do leak tests. We use a sizing tube to make sure that we calibrate the stomach exactly right. And by doing it laparoscopically or robotically, it minimizes the stress in the body. And 90% of our patients go home one day after surgery. And we're actually even changing the paradigm by letting patients go home by providing hospital level monitoring. We call it home hospital for surgery. You still have nurses around at your home, doctors make home visits, the same remote monitoring of your heart rate, being able to do labs and tests all at home to really speed the recovery, but still have that same level of medical vigilance on how well you do. There's some of the risk that comes with anesthesia and the stress, and that includes a risk for blood clots. And that's why we look at the risk of each individual patient and will prescribe medications, blood thinners to help decrease the risk of blood clots afterwards. And then there's a risk of heart attack and stroke that all sort of come with the comorbidities along with obesity. So yes, there is definitely risks to the operation, but a lot of benefit as well, and that's why it's so important for patients to have this conversation early and come fully informed on what the risks and benefits are.
Right, and I think that you're absolutely right. I mean, the whole point of doing or taking a surgical approach is really because there are significant benefits, as you've described, in terms of outcomes and improvement in outcomes in patients who are significantly overweight. So I think we're just coming up to the end of the hour, and so I would really like to thank our speakers. They've both given excellent talks and been very engaging in their answers, and we really appreciate you joining us today. I'd like to thank Senate at the National Kidney Foundation and from the National Kidney Foundation for the support of this program with the Brigham and Women's Hospital. And I'd like to thank our attendees. Thank you very much for coming. I hope you enjoyed this, and we look forward to seeing you again at another Kidney Crossroads. We are hoping actually to do an extra Kidney Crossroads potentially next week or the week after to talk about some of the data that's coming out from the studies that have looked at COVID vaccination, immunosuppressed and transplant patients. I know that we get a lot of questions about this and about concerns and risks. And we have new data from a study that we've carried out at the Brigham. And I think it's really important to communicate all this information to our transplant community. So thank you very much, everybody, and I hope to see you next time. And with that, we will wrap up. Thanks once again. Bye-bye.